Yes, share చేయండి.
Yeah, Vinay, funny.
Yes, sir, you're audible.
You are not audible.
Is sir then now I am audible?
Vinay, I think everybody's voices are audible very clearly.
Yes, I am audible, but speakers are unable to. Sir,
No.
Narasimhan sir, can you say hi?
Hello.
Rambabu Narasimhan sir voice is very
Narasimhan
clearly
sir, can you
audible.
speak?
Please, Rambabu, please listen.
Animesh.
Narasimhan voice is very clearly audible.
Dr. Rambabu,
So
all the voices
you are able to
audible
listen
clearly.
me.
Yes.
I am audible.
Yeah, you are
Yeah,
audible.
Vinay, I am audible.
Dr. Rambabu, all the voices are
Hello,
audible. You can start the program also. There's no problem.
So I think the problem is he's
I'm
not.
sending a message on WhatsApp. I think the problem is with his speech.
Problem is with Rambabu. Right. Nee, but if he's not able to hear what we are saying, then he won't be able to ask us questions.
Yeah.
I wonder if we should at least introduce each other, and that will save some time while we wait for Dr. Rambabu's audio. What do others think?
Sure, why not? We can do that.
Dr. Narasimhan, how are you?
I'm Dr. Narasimhan. I'm with Apollo Hospitals for the past 30 years as a pulmonologist there, and I'm also the chairman of the Respiratory Research Foundation of India. So I think probably I'm here to share some of my thoughts and ideas and opinions. Because every day the opinion is changing, on COVID.
Yeah, the pandemic that continues to give back. Dr. Ray?
Yeah, so my name is Animesh
Okay,
Rai.
now I am audible.
Yes.
You are always audible, Dr. Rambabu. You should tell us whether we are audible to you.
Yeah, so good evening, everyone.
Yeah.
I just spoke to Dr. Rambabu. Maybe he's having a little technical glitch. Sorry for the delay. Dr. Rambabu will be joining and continuing this webinar. So I welcome all the speakers. I'm Dr. Vinod Kumar. I'm project director of the AP Health System Strengthening Project and also the nodal officer for the clinical management protocol. It was quite unexpected for me to start this webinar because of the technical problem I had to pitch in. So I welcome Mr. Animesh Ray. We'll be seeing your National Combined Grand Rounds, such wonderful webinars you'll be giving. Ms. Bhakti Hansoti overseas. I'm sure it is quite some odd hours for you. Thanks for joining us at this time. Dr. Narasimhan, and as and when I will be able to see the other speakers, I'll invite them and I'll request them to start their webinars. I request all the speakers to be ready with your presentations, open it in the separate window so that it is ready to share.
Hey, so we were not supposed to have any presentations. Only it was supposed to be a panel discussion. Yeah.
I thought, the same I have. I don't have any presentations to make. I thought we just share our thoughts and ideas.
All right. All right.
Yeah. Huh? Okay.
Okay.
Can
Thank
be
you,
a form of
doctor.
a question and answer session. It will be. That will be great. All of us can share our ideas.
Let's do this.
Yeah,
So
yeah.
the time now is 5:10. So kindly give us
ఇది
10 minutes. Let's start this sharp at 5:20. Let's fix up all the glitches and let's bring structure to this so that without waste of time, we can start this with intensity. Kindly bear with us till 5:20. Thank you.
Doc, it's about an hour's session because I have a session at 6:10.
Yeah. Got it, Dr. Narasimhan. It's not duly noted.
So 1 hour, no? It's about an hour.
The webinar is up to 7 p.m. for 2 hours.
Oh.
So we will slot your talk or the discussion in an appropriate manner so that your other commitments are taken care of, doctor.
వినయ్ నా ఏమైంది?
Rambabu sir, we are audible. Am I audible? Please select your microphone button and then select speaker.
సార్ హలో
Ram Babu gar, your audio is clear. Can you hear me?
హలో సార్
Rambabu, your voice is clear. It's audible.
మీ వాయిస్ మీరు మాట్లాడండి సార్.
Am I audible?
Hello. Good evening. నా వాయిస్ రావటం లేదా మీకు జూమ్ లో?
కంప్యూటర్లో రావట్లేదు. సో ఇన్ ద మీన్ వైల్ సో నేను స్టార్ట్ చేసేస్తాను సార్. Hello, I am audible.
Yes, you are audible.
Okay,
Please go.
there is some problem in my microphone probably, so I am unable to listen anyone. So, but so you are audible, so it doesn't matter. So I think sorry for the delay. So much of delay happened. So welcome to the APCOVinar, and this is a particularly very important one to remove the confusion among the clinicians so who are treating the COVID. So many drugs so we are using, so we know the lot of mechanisms, and in spite of that there is a lot of confusion. So many guidelines, so every institution has made their own guidelines, and clinicians are writing their own prescriptions. So everything is going on. To clarify a little bit, so what is happening in USA and what is happening in AIMS, and what is happening in Chennai and Delhi also. So Dr. Anil Guttu is suddenly, so he is a task force member also. You know that how much surge is there. So he went for that meeting, so he will join in between there. So here this webinar is, it's a dialogue or the discussion point. So we don't want to go for the one-way traffic, this one. So before going to this one, so we will first, I would like to first clarify the things from the what is happening here. Let us share my screen. I think so it is visible to everyone.
Yes,
Yeah.
sir.
Yes,
sir, it's visible.
Yes, sir.
Yeah. Now, so first we will start the most important addition of the Government of India, and also ICMR, and also the AIMS protocols included the ivermectin in a mild case or the asymptomatic case or the home isolation case in Medu. So that means that can be included, can be added. So as we know that aware that it's a antiviral property how it is, but we know that it's a antiparasitic, and it can almost studied in HIV, dengue, simian, Zika, and now the influenza. So almost all the RNA virus testing. So how probability of this one? So as you know that, so you know the all the mechanism of the COVID. There is endocytosis, so host RNA ribosymation will occur, but there is a long polypeptide chain. So to break that, there is a functional proteins, so has to occur. For that, there is a RNA dependent RNA polymerase enzyme has to be there. From there, so there is a lot of RNAs are coming. So here it is okay, but after this, what will happen? From here, to enter into the nucleus, there must be some transporters are needed. From this is imported alpha and imported beta 1 heterodimers. For this nucleus core complex will be there. From this pore, so the virus will enter into this one and destroy the host to defense mechanism. Here the probability of the ivermectin may block this, and that may cause little bit antiviral effect here. But there are a lot of studies occur, 200 more than studies, but showing that not that much effective here. So this is the total not that much sufficient to strongly effective, but still, so everybody is using this one. Let us take the opinion from the Dr. Narsimhan. So he is treating the cases since 1.5 year nearly. So Dr. Narasimhan, over to you regarding ivermectin. What's your take?
Doc, I don't use ivermectin at all because there is no evidence to say that it is a useful drug for COVID. I think it's early in the pandemic. There were a lot of drugs that came into the market, right from chloroquine, azithromycin, and ivermectin was one among them. And now over the years, there are a lot of studies have come and proven that they have got no role at all, either in when you are treating the patients at home or as an outpatient treatment or as anything else. So I don't use ivermectin at all in my practice. Dr. Rambabu? Dr. Animesh?
Yeah, so thank you. So regarding ivermectin and COVID-19, I mean, I would agree with Dr. Narasimhan that, ivermectin as such has not shown to be of much benefit. Now, we have included ivermectin in our protocol as far as mild COVID-19 is concerned. Now, if we look at, ivermectin, without going into too much of details, we have got around 3 RCTs which talks about ivermectin, one from Bangladesh, the other from Argentina, which is yet to be published, and the other from Colombia, which was published in JAMA. Now this Bangladesh study, it showed some benefit in reducing, hastening virological clearance, that is in clearing the virus quickly as compared to placebo. While the study from Colombia, which was published in JAMA, it did not show any benefit in any of the outcomes, be it virological clearance or be it increased time to recovery. So the reason we have still included that in mild COVID-19 is that we felt that ivermectin in the dose of 12 milligram once a day for 3 to 5 days, it won't produce much of side effects. It might not be that much of beneficial to the mild patients, but probably it is not going to be harmful as well, because a problem that we face in answering to a question is that if we have COVID-19, mild as it is, don't you think that we should receive any treatment? So it is often, the need for this that has led to, us using, or a lot of physicians using ivermectin in COVID-19, right? But I would agree that we would require more data before we can say that ivermectin is producing benefit even in mild COVID-19 patients. Yeah, so that's it.
Yeah, thank you, Animesh. So, Dr. Bhakti?
Nothing to add. I completely concur. There is no evidence for mild or severe cases of COVID. I think there is some anti-inflammatory properties, which were the same as what we saw with azithromycin and doxycycline. But, and as an isolated treatment, it is neither curative nor shown to provide a reduction in time of symptoms. I think Dr. Ray's suggestion about why it was included in our protocol, it is useful and should be considered if you're developing your own hospital protocols.
Yeah. So now again there is a confusion. May I know I didn't listen to Dr. Narasimhan's. Sir, your take on, sir?
Yeah, I give a very strong opinion saying that both ivermectin, azithromycin, doxy, they're all not considered in my treatment protocol at all.
Nice, sir.
Even
Okay.
patient treatment or when the patient is in isolation also, I don't think of these drugs, because early in the phase, that's what I was just telling, in the early phase of our treatment, we had a lot of drugs coming into the armamentarium of COVID to treat, and now there are a lot of trials have come and which have proven that they are of no use at all. Mild COVID recover without any treatment. They don't need any treatment. So we don't use them as a routine. And there are people who use it as maybe for some placebo effect or something. Patient feel that nothing is being done, or they use like that. But otherwise, scientifically, there is no evidence to say that it has a role in.
Yeah. So Animesh, so for once the protocols from the ICMR or the government of India collaboration with AIMS may do. So what do you mean by that may do? So we can take it as granted for do for everybody. Animesh?
Yeah, so you're talking about the our protocol?
Yeah, ivermectin.
Yeah, so mild disease, it is mentioned that tablet ivermectin to be considered, right?
Yes.
And we have mentioned that used to be avoided in pregnant and lactating women. So, I mean, we are clear about this. It may be given to mild COVID-19 patients, though if the patient is able to understand that, probably not much benefit is going to accrue from that, right?
Yeah.
So if the patient and the physicians, they're okay with, a drug which has got doubtful efficacy, but, theoretical efficacy, perhaps no evidence as such, but which is otherwise safe, and if the patient wants to use that, we tell them to use it. Otherwise, I know a lot of my friends, compatriots from the department who have had COVID-19, mild COVID-19, and who have not taken themselves ivermectin, right? So I don't think it is a life. It changes the outcome in any plausible way.
Yeah. One more thing is that Sundaracharya garu. So we will have the discussion later. So once the speakers will have to give their opinion about all the drugs, then we will discuss. So if we are going on in between discuss, there is a lot of problem will be there. Okay. So I think so only my doubt is here, when the in vitro study only with a huge amount of drug causes this efficacy. So then with this 12 milligrams for the human beings, is it okay?
So I'm not talking about the the theoretical basis. Our evidence is based on a trial from Bangladesh, which is in public domain. If you would look that up, they have used 12 milligram once a day for 3 to 5 days, and they had shown that there is faster virological clearance. So it's not based on some biological plausibility. No, that's not how we practice evidence-based medicine, or we would encourage anybody to practice evidence-based medicine. It is based on the evidence which is available from a neighboring country of Bangladesh, who had done an RCT, who had published it. There may be some debate about the quality of the study has been done, and since it had some methodological limitations, we are not saying that it to be used in everybody. But yes, that's the reason why we have kept it in our provision, that it may be considered in mild COVID-19 patients, with the understanding that probably it is not going to change the outcome.
Yeah. So I think that, so with this, so we'll close about the discussion about the ivermectin. Now it is the interesting thing that, so they added hydroxychloroquine, or either ivermectin or the hydroxychloroquine. So there is a lot of discussion about hydroxychloroquine, and solitary trial also ICMR stopped in between. And suddenly now hydroxychloroquine can be either ivermectin or hydroxychloroquine. What's your take on, sir? Narasimhan, sir?
My opinion on these oral drugs like ivermectin, doxy, azithromycin, and all these drugs has not changed at all over period, because they have no role at all. Because I don't consider mild COVID is something that should be treated. We just need to give him a good talk to the patient. The oral therapy is much more important. There are a lot of people have been mentioning, should these drugs be mentioned at all? I strongly feel that these drugs need not be mentioned at all in the treatment protocol at all, because they have absolutely no role in them. The worry about the COVID is when the patient enters into a category B, that is the patient who needs the hospitalization based on certain parameters, which I think we'll be discussing somewhere down the lane. So in such a situation, if you have a patient who just has a mild COVID, I don't know, the definition is still very nebulous with regards to that mild COVID. So I don't treat this patient, I just reassure them and send them home. And as usual, we are seeing in the studies, more than 95% of the people are people who are mild COVIDs, probably asymptomatic COVIDs, or symptomatic COVIDs who do very well without anything. That's what I feel. I have absolutely no idea. In the beginning, yes, we were using it for the first last year. Probably, if you had asked me, maybe I would have talked about the mechanism of action of chloro and all those things. But there are so many trials that have come. This already had a very clearly proved that they have got no at all. I don't use them at all, Dr. Ambav. I think I like to hear from what Dr. Bhakti and Animesh Roy do in their countries.
We lost the Animesh last. So, Bhakti,
Hi.
what's your take on?
I agree completely. I'm not convinced that mild COVID needs treatment. And I think the challenge here is that by treating a condition that will resolve by itself in the majority of your patients, you're going to cause potential harm. So none of these drugs are without consequences. Hydroxychloroquine in particular, there was some early data to suggest that there was secondary cardiac instability. But with doxycycline, one of the concerns is that it does cause gastrointestinal side effects. So you're sick with COVID, and then suddenly you complicate that by developing nausea, vomiting, and abdominal pain, which then confuses the clinical picture and then diverts resources. So I'm in complete agreement. With hydroxychloroquine in particular, there is no recommendations to use and no benefits, but there's actually guidelines from the WHO, the Society of Critical Care Medicine, recommending against the prophylactic use of hydroxychloroquine, either as a preventative measure or for treatment of mild COVID.
Thank you. Dr. Animesh?
Yeah. So again, if you would see the AIMS, ICMR, MOHFW guidelines, we have mentioned ivermectin and hydroxychloroquine within, as you said, may dos, right? Either ivermectin or hydroxychloroquine. But again, hydroxychloroquine does not have, any evidence to say that it really works. This is not specifically there in our own institutional guidelines. So there is one institutional algorithm which does not include hydroxychloroquine, because we were not convinced with hydroxychloroquine, but it is there in the AIMS ICMR combined algorithm. The reason being, I am told that ICMR from their own registry, they have some data about hydroxychloroquine, which was shared with the experts in a closed door meeting, which showed some benefit, though of low certainty, in patients with mild COVID-19. So my take on this is, again, they are optional. They are made use, they include ivermectin, hydroxychloroquine, and something probably which we are going to discuss, inhaled budesonide. These are again of low certainty. It's not sure whether they produce any benefit, to what degree they produce any benefit, and if at all they produce any benefit, whether they are tangible clinical benefits. Tangible means faster time to recovery. Tangible means a reduced chance to severity. There's no data to to prove that. What is more important is the top column, which says the must do's. I mean, supportive treatment and infection control and monitoring. Those are definitely much more important than these may do's.
Yeah, because so we are discussing this much of time we are giving. More than 80% of cases are mild or the asymptomatic. So if we take that, if the 1 crore are affected, so that means that more than 80 lakhs are these people are going on using all these drugs. So that's why. So now interesting one is, so I think Narasimhan sir is not getting the asthmatic or the COPD cases because of using all these oral steroids or the inhalers, all these 1.5 years. So there is again, so inclusion of this inhaled budesonide corticosteroid stoic study that shows age factor less than 40 and more than 40, sex, and the comorbidities with or without. So here they used the turbohaler 800 micrograms, and they found that primary and the secondary endpoints. So hospital staying, and then with the happy of self-reported clinical recovery, they stopped the study. They felt that it's okay. And here you can see that primary, that is the hospital staying, is 3% when compared to this placebo. It's 11%. That means 15%, 11 cases. So this is very good, but the shorter recovery period for this is only 1 day is there, and the temperature and the fever is also 27% when compared to the 57% in this placebo group. So now I would like to share the views of the Dr. Narasimhan is the most eligible person to tell about this. What is the role of inhaled steroid in COVID early stages? What do you mean by the early? Whether it is asymptomatic or some fever or the any inflammation should be there, or is it really going to be effective? Shall we keep in the home isolation kits? So much of costliest one. Dr. Narasimhan sir.
Was this study funded by AstraZeneca? I think it is, if I'm right.
Yeah.
So that's one of the reasons why I take this study with a pinch of salt. One. Number two is the number of participants is only about 146. 146 people only in this study, with or without budesonide. That's one of the reasons. So the study is too small and is not extremely powerful to say that we can give this as one of the guidelines to say that we can treat all patients with COVID with budesonide. Having said that, I must also add that in our first 6 months of our COVID, we kept telling that patients who are asthmatics and patients who are COPD patients and who are on inhalers did not develop COVID that well as patients who had relatively normal lungs but had COVID with systemic. They had a lot of lung problems. In other words, we did not see much of COVID in the early phase when you're seeing as outpatients, our asthma numbers, our COVID numbers came down. People who were asthmatic were coming only for asthma. Most of these patients were on some inhaled steroids. This is just an observation. I made this observation in one of my articles in Hindu too, that my COVID numbers are relatively less compared to the pulmonary problems which is being mentioned. Having said that, I must also add now that nowadays we are seeing quite a number of COVID with respiratory, with tuberculosis, with so many other things, and plus as a guideline, we are testing most of the patients who have some chest opacities for RT-PCR, and we are seeing them as positive. One. Number two is most of the patients who are hospitalized are getting some nebulized form of steroids. I don't think I can say along with other antivirals and other drugs. I can't exactly say whether this inhaled steroids has got a role in this COVID at all. I have my own doubts on that aspect of it. As I said, I take it to the films of. So there's another MRC study wherein they've done about thousands and thousands of people with budesonide, but I think data is yet to come. But even in them, my observation is that we do this as a routine along with many other drugs. I think there is no subtraction point to say that budesonide does the job. That's my take on that.
Thank you. Thank you very much, sir. Dr. Animesh.
Yeah. So we had also included this inhaled budesonide again within May dose because we thought that this was an uncertain area. This STOIC trial, as it is called, it happened in Fulham, UK. It was a properly conducted trial, and on paper it is a properly conducted trial, and it was published in Lancet Respiratory Medicine recently. Right. It was obviously sponsored by pharma company, but it is written clearly that they had no role in designing the study, collecting information, analyzing the study, and writing the manuscript. So there is transparency as far as the role of pharmaceuticals are concerned. Now, the proposition laid down by this study is very, very attractive. That till now we know that mild is majority 80%, and we do not have any drug which can change the probability of changing from mild to moderate. Yeah. So there is no drug which can do that. So inhaled budesonide is one of the promising drugs which shows that there might be some role of inhaled budesonide. Having said that, as Dr. Narasimhan said, there has been another study, a principal trial, which is still in its preprint. Thousands of patients, which again, the population is different. Here it is all patients. There it is mainly patients having high risk, right? And there the outcome is a little different. Here the outcome is decreased chance of hospitalization. There it was seen that again 2 or 3 days of recovery was there, right? So the point which I'm trying to make is that that in the light of the present evidence, till the time the principal trial comes out and it has been ratified and examined and analyzed by all the readers, and a judgment has been passed on this, we feel that there might be a potential role of budesonide, inhaled budesonide. So that's the reason why again we have put it into May dose, right? But I think only time would tell whether inhaled budesonide would act as a game changer in preventing progression of mild COVID-19 patients to moderate severe COVID-19 patients. So our algorithm mentions that it may be done again with the understanding that this evidence might also change with passing time.
Thank you, sir. Dr. Bhakti, can you say anything?
So I just want to make a caveat to all of us. So we're talking about the use of inhaled budesonide in all comers, but there is a subset of patients who have underlying reactive airway disease, i.e. asthma or COPD, who during the cytokine storm can have progression or a reactive airway disease pattern. So they'll present with wheezing and respiratory failure. Now, in those patients, due to the underlying pathophysiology, it is likely that their oxygen consumption is going to be longer because they're going to be ill for longer. And I think in that subset of patients, to help manage the underlying reactive airway disease, there is a role for inhaled budesonide. And that role should be carefully considered because it will also act as an oxygen conservation strategy, i.e. the patient will be getting better quicker, will need less supplemental oxygen, and have a lower likelihood of progression to respiratory failure. I think that decision is not made on all comers, and it should not be preventative or a blanket treatment. But in a subset of patients that have underlying wheezing, respiratory failure, this may serve to decrease the burden of respiration and secondary fatigue. Dr. Ray, what do you think of that proposal, that suggestion?
Yeah, sure. So, I completely agree with you. So they had also looked at this. One of the basis for doing this trial was they had noticed that lesser and lesser, as Professor Rambo had also indicated that initially that Dr. Narasimhan is probably seeing less of COPD or asthma patients, because the authors thought that probably these patients, they were already using a lot of inhaled budesonide, and so they were having less severe COVID-19. So this led to this study being designed. However, they have addressed it partially in their study, in the sense that they have tried to compare asthma patients having airway disease at baseline between the two groups, and they were found to be equal. So those who received inhaled budesonide and those who did not inhale budesonide, the proportion of asthmatic patients, they were kind of equal. So I'm not sure whether we can say that it's only obstructive airway disease patients who would be benefiting from this.
If that be the case, is there a role at all for budesonide in the guideline? That's what my take is. Because some patients, we start them on budesonide based nebulizer, some are on proticusone based nebulizer, some are on other groups too. I don't think we can point and say that budesonide alone has a role. That's what my comments on that Lancet. I actually wrote to them, how can we say that only budesonide has a role? After all, it's a steroid. It has a mechanism of action, and most of steroids have some mechanism of action. The biochemical properties are different. One is lipophilic, one is not. But the ultimate role is only the prevention of inflammation. So if the inflammation is the only role, any steroid should be good enough. Why add only budesonide and give an undue importance to the budesonide? That's what
So
I had
think, yeah, exactly. So that is, I think, where the pharmaceutical role comes into play. They had a hand in choosing the drug. So so this is a very well established drug in UK, and AstraZeneca, as we know, is a European company. So so that's where that role is. I agree with you. So it should be generic. It should not be drug.
Hello.
Yeah, it should not be.
Can I turn the?
One just comment, Dr. Ray.
Very good.
Yeah, please.
Yeah. Can we mute? So one just additional comment. In ventilated patients who are having trouble with synchrony with the vent, inhaled steroids in line may benefit as a cough suppressant and improve synchrony with the vent and decrease your likelihood of vent failure. So that's just, but that is, a case by case, and it's more to do with management of a vented patient than to do with the underlying inflammatory mechanism for COVID-19.
Okay, thank you very much. So we have to discuss so many things. So because these are the two new things added, so all others are almost what we are using regularly since 1 year, more than 1 year. So I think so to conclude, it's only ivermectin, HCQ, and inhaled budesonide, only MADUS. So I think in ivermectin may or may not used or the advised from the government in home isolation kit. What, sir? Narasimhan, sir?
Ivermectin?
Ivermectin in home isolation kit.
No, I have a strong opinion on that. When a drug does not have any evidence or any level of evidence to prove that it is effective,
so
I don't think
it means that so we want to give the clarification to the participants. There are private practitioners and the government working the superintendents and all those things. So we have two problems. We have to set up the home isolation kit from the government side, and we are giving a free of cost to all the home isolation and the asymptomatic patients or the mild patients. Shall we include the ivermectin in this home isolation kit or not? So we want to clarify. And also we have to give the guidelines to the practitioners. Shall they go for this just like that ivermectin, doxy or azithro, they are going on writing. If they say fever, if the COVID, so they are just liking. So final taking.
My opinion is no.
Yes, thank you, sir. Anyways, sir, yes, no.
So again, I think it's conditional. So, so mild COVID-19 patient, I'll tell you, if a patient comes to me, I would say that don't take any medications, right? But if he calls me on the second day and say, I'm still having fever, doctor, what do you think you want? Don't you want any other drug to be given? No antibiotics, no nothing. What about ivermectin? So, two options. One, I tell him, no, there is no, no multi-center, properly designed, large RCTs, which shows, ivermectin is useful. So if he agrees to that, right, don't take ivermectin, don't take HCQS. But I mean, the chances are that, he's going to anyway take it, right? So my point is, it depends on the patient. If he understands that probably not much benefit, don't give him. If you think that, he wants something, so we can probably give something which is innocuous like ivermectin. That's what my point is.
Yeah.
Can I
Thank you
come
very
in,
much.
Dr. Rambabu?
Yeah.
It's Nageshwar Bandla from UK. Can I just come in for a minute?
Yeah, please.
Is that okay? Yeah, sorry to interrupt.
Yeah, please.
Yeah. So I just wanted to, give a little input on this as well. Either budesonide, I've been following the meeting from the time that budesonide is discussed, and then we followed on to ivermectin. Essentially, either of these two things is a standard of practice in United Kingdom. So I don't think this is something that we make it as a standard of care anywhere in the world until substantial evidence comes in. And following the discussion, I just wanted to be sure why we would like to deliver our treatment based on the patient demands. There is a considerable amount of anxiety, panic, fear, and abuse happening out. And as a medical fraternity, a great responsibility lies on our shoulders that we deliver proper evidence-based standard treatment rather than subjecting patients to these drugs that are going through research at the moment.
Thank you, sir. Thank you.
One comment,
Nagesh.
Rambabu.
Yeah, please, sir.
I completely agree with Dr. Bandla now. I think we should give cut guidelines. When someone asks you, if you give him there is a study, there is a trial, its choice is yours, means it is not a guideline. You form a guideline, means yes or no. You give a guideline saying it's ivermectin. No, we don't give ivermectin. Or you want to add into the guideline, you must add it. But the guidelines are formed based on the data. Like Dr. Nag said, I don't think there is a standard of care is no longer, in our country at least, we don't use ivermectin, azithromycin in a home care kit or as an outpatient man. That's my take on that.
Yeah, these medications should not be driven by patient demands.
Exactly. Yeah, I agree now. Yeah.
Thank you very much. Yeah. So we'll conclude with this this home isolation regarding this ivermectin and HCQ anyhow nobody is interested now. And also regarding the inhalation budesonide, it's again the query. So shall we go or not? So almost so it's a mild or asymptomatic patients, no treatment, is only paracetamol. Yeah, I think so. We are concluding with this these drugs. So we will go for the chat box or any other questions are there for anybody. So at the end, so we will take. And then here something is vitamin D3 is we are using for every kit. Probably decreased vitamin D3 decreases the T regulatory lymphocytes, which is most important for the cytokine storm or the inflammation. And also we know that decreased vitamin D3 leads to the increased thrombotic episodes. Probably we are using vitamin D3 in home isolation kits and the patients. Narasimhan sir.
My experience with that is very low because in our country, every alternate patient has a decreased vitamin D levels. So I don't think we can give much importance for cyclosine, the storm or a thrombotic episode. I think D dimer or CRP is a much better indicator than a D3 levels, because if you have a patient in front of you and whom you think he may progress on to a severe COVID, I think you would ask for a CRP and a D dimer levels to see whether he is likely to get a cytokine storm or whether we should add some anti-inflammatory like IL-6 drugs or and so on, anticoagulants or something. I don't think D3 would be of, at least we are not using D3 as one of the drugs which I would predict whether this patient would be prone for thrombotic. I'd like to hear from others.
Yeah, Animesh?
Yeah, so I mean, so this comes within the the purview of supplements, vitamin C, zinc, and vitamin D.
Add-on.
Right, add-ons, right. So again, not much role, as Dr. Narasimhan said. More than 95% of patients in Delhi, that is, attending a hospital, 90 to 95%, they have vitamin D deficiency, and we have no trial on Indian population or otherwise which shows that vitamin D helps. These are again, theoretical, that it decreases thrombotic episodes if supplemented. So we are not using them in our patients.
Yeah, thank you, sir. Dr. Bhakti?
So the most useful trial to support this is the Victus study, which is the vitamins. These are the use of supplements. Victus was vitamin C times
Vinay, can you unmute everybody?
Yeah, so the Victus study looked at the use of vitamin C, thiamine, and hydrocortisone. It was a multi-centered, multi-institutional, randomized, double-blind controlled trial in patients with undefined sepsis. And even in that population, there was absolutely no benefit of the use of supplements on decreasing the number of ventilator days or vasopressor-free days in patients with severe sepsis. So there is no evidence. Anecdotally, though, there is no harm also from vitamin supplementation.
Yeah, thank you. So now we can go to, so it's all the, whether it is multivitamin, C, zinc, and D3, and this ivermectin, and also the budesonide inhaler. It's optional, and it's a call for that institution probably. So this is what we are concluding this one. So next we will go to the important drug. Here something very important one. So it's removed from the Government of India main guidelines. Remdesivir has been removed from the guidelines, and as we know that Remdesivir is almost may not be the game changer, but before entering into the nucleus, so it's going to affect over here and before that one. And as you know that once there is endocytosis, RNA dependent DNA polymerase, this is RNA, this creates the defective, and this creates the difficulty to enter into the nucleus. So this is what is the routine mechanism, and we know that we are using left and right. There is a serious hype regarding this remdesivir, but suddenly it is dropped from the main guidelines, and it comes into the only EUA or otherwise whenever necessary, either emergency drug. This little bit difficult to understand. Dr. Animesh, can you say anything?
Yeah, so there's a lot of confusion regarding remdesivir. I think the first thing which needs to be said about remdesivir is that it's not a magic bullet. It does not uniformly help in all moderate to severe COVID-19 patients. It does not. So, if we look at trials, there is only one trial, ACT trial, a US-based trial, a very well conducted trial, which showed benefit of remdesivir only in a subgroup. Which subgroup? Patients who are having low flow oxygen, that is, they were not on high flow oxygen, NIV or ventilator, and these patients, they were seen to have decreased time to recovery around 5 days, and they had better mortality. So they died less. But this was only in a subgroup analysis, right? So the whole trial as such, all severe COVID-19 patients or moderate COVID-19 patients who are on mechanical ventilation, etc., if you include them as a whole, they were not beneficial, right? So based on this subgroup analysis of ACT trial, remdesivir was used in moderate and severe COVID-19 patients who were on low flow oxygen, right? So that's what we were following. Now, after that, there have been a number of trials, including the Solidarity trial, of which we were a part, which also included remdesivir. Now, this was a very large trial, multi-country, multi-center, and it included, very large number of patients. And when it was published, the WHO, which was the coordinating organization behind this, they also published a meta-analysis along with this, and they showed that there is not much benefit of remdesivir in any particular group. So this this debate about remdesivir, it still goes on. What we have realized and what we have mentioned in our guideline is that the benefit of remdesivir, if it is there, would only be in those patients of moderate to severe COVID-19 who are on low flow oxygen, face mask, nasal prong. It is not for those patients who are on high flow oxygen, who are on NIV, who are on mechanical ventilation, right? And so in these particular patients, they might lead to some mortality benefit, and they might lead to some faster time to recovery. So that is the reason why it is still there in our guidelines, but it has been relegated to off-label use. So we are not saying that use remdesivir for all patients. Only in a particular subgroup you might choose to use it. CDC also, follows the same thing. CDC also mentions in their guidelines that there is not present evidence is not conclusive about remdesivir. CDC also says that it can be used in low flow severe COVID-19 patients requiring low flow oxygen.
Thank you, Dr. Ray. Dr. Narasimhan, sir.
I think remdesivir is a good drug. There's no doubt about it. But one has to be very careful in choosing when to use the remdesivir. The reason why this has been relegated to one of this off-label use is because there is an indiscriminate use of remdesivir in our country. Because patients who were hospitalized were being given remdesivir indiscriminately. Remdesivir is the drug which can only shorten the serious duration of it. That is, a serious duration of the illness can be shortened. If you have a patient who is in category B on oxygen and who is getting prolonged, usually you expect the COVID, the critical phase, 4 days, 5 days, they start recovering within a day 10, they are out of the hospital. If you think this patient who is in category B is slightly getting prolonged, in that scenario, you can start these patients on remdesivir to shorten the duration of the illness, but not to decrease the viral load, to shorten the duration of the symptoms, and also prevent him from going on to the mechanical ventilation or NIV and more serious problems. So which means patients who are on ventilators might take what we follow in our hospital. Patients who are on a mechanical ventilation, or when the patient is shifted on a mechanical ventilation from some other hospital to a corporate hospital, I think remdesivir has got no role in this patient. That's a major chunk, which most of the people do. Patient is on a ventilator. As a routine, we start them on a remdesivir loading dose, and then the 5 days it has become a rigmarole for many of the physicians. I think that aspect is what one should be very careful in choosing remdesivir. So remdesivir is not a great antiviral drug, but in a subgroup, it has shown that it can prevent the progression from moderate to the severe. So which means you can remove all those patients who are on ventilator after. I don't think there is any role for remdesivir because there are already damages occurred. Patient who has gone on a ventilator is either in a type 2 failure or in ARDS due to some vascular event or some other infection or something like that, which means remdesivir is not going to help such patients. So you must identify. I think that identification is what is very important. In identifying such people is the role of these CRPs or your D dimers or your ferritin levels or your IL-6 values. So you need to identify with the clinical parameter of on he is needing more oxygen, his demands are increasing. You think he's going to improve, but his demands gradually increasing. In such patients, maybe yes, there is a role for a remdesivir. Otherwise, it has got no bigger role in the management of COVID. In category C, where the patient is in respiratory failure or on a ventilator, or you think of ECMO for such patients, there they have got no role at all.
Thank you. Thank you very much, sir. So now I invite Dr. Anil Guttu. He is the Director and Professor of Medicine in Lady Harding's Medical College Hospital, and is a COVID task force member also. Vinay, can you unmute? Sir, can you unmute yourself?
Sir, there is no name with the Anil.
I am able to see him.
So what's an Anil?
Yeah, you can see.
I think it might got disconnected, sir. But as of now, there is no name with the Anil Kuttu.
Yeah. Okay. Right. Right. Now, Bhakti. So, can you conclude this one, Remdesivir?
Sure. So in conclusion, I would say that there is no evidence and there's no recommendation to use remdesivir in mechanically ventilated patients. Other than CDC, most other organizations have come out with a specific statement against the use of remdesivir in mechanically ventilated patients due to the findings of the Solidarity trial. Remdesivir should be used or could be used. It's still inconclusive of how much actual benefit will be achieved in patients who have mild COVID disease. And by mild, we're defining that as on some oxygen, nasal cannula, but no mechanical oxygen, no BiPAP, no CPAP, and used within 7 days of symptom onset. So late or delayed use of remdesivir is also not beneficial. And I think that's where the challenge is, right? So when you think about it from an implementation perspective, there's been delays in diagnosis due to the delay availability of testing. So many patients, by the time they're seeing their clinician, have already passed that 5 to 7 days of initial symptom onset. And so the challenge is getting remdesivir to the patient early enough where there is some benefit.
Thank you. So, Bandla from UK, what's your take on?
Thank you, Dr. Rambabu. I agree with the previous two speakers. We have stopped using remdesivir pretty much. I mean, I'm a consultant in critical care, and I have to say we have never used it as much. And it was when it was in the early stages, it was under the emergency use authorization EUA program in UK as well, and we had to go through a lot of permissions to use it in the initial days. But then it was pretty much only for the patients that it was started on the ward when they presented with moderate symptoms on oxygen therapy. If they presented to intensive care unit, we carried on using it. But if they were not commenced on remdesivir and they presented to intensive care unit for any form of mechanical ventilatory support, we have never initiated the treatment. So the message, I think, needs to be very clear out to the medical fraternity in terms of the specific group of patients that may benefit from this, because as I see from the national media that it is widely abused, and that is probably the reason why there is so much scarcity of the drug for the people that could potentially benefit from it. So I think if anything, it has to be used in a very selected group of patients. Most patients that present to critical care are outside the window, and most patients do not present to the hospital within a week. Our cutoff was 10 days after symptom onset, but with most patients do not present to the hospital within a week of symptom onset. So I think there is very few or selected patients that would benefit from remdesivir, in my honest opinion. Thank you.
So thank you very much. So everybody is agreed that so remdesivir can be used only in moderate cases and with oxygen requirement, and not the severe patients who are unventilated or otherwise HFNO high flow is there, not with the demand of the patient or the attendants. So it should be streamlined. This one. So thank you very much. So now we will go to the tocilizumab. So everybody knows that. So it's a IL-6 inhibitor. So prevent the cytokine storm. So how the action from the JAK-STAT or the PAKV pathways. So everybody is aware of that. So now we have to go through the take on for this how much it is useful. So Narasimhan sir, so you are saying more than for 15 months. So what's your take on, sir?
The unfortunate thing is many patients are aware of these names, tocilizumab, remdesivir. They will straight away come and ask you, why not we start this, why not we do that, actually. Tocilizumab is one such drug one has to be extremely careful. I think one has to be very careful in using this drug because this is used in other diseases like rheumatoid arthritis and so on, where they do not have a respiratory problem. But one of the important side effects of tocilizumab is respiratory infections, severe respiratory can cause. It means tocilizumab can do more harm than good in patients if you do not select the patient properly. Very, very important message that one should always think of. One. Number two, I think the role of tocilizumab is like remdesivir only. Before you intubate the patient, if you have a patient who has been hospitalized, whose CRP is pretty high and whose IL-6 is pretty high, they are the patients in whom you suspect that this patient is likely to have a cytokine storm. In such patients, if you use tocilizumab, maybe there will be some benefit in that. I think there are no straightforward studies to say that it benefits. Maybe there is some benefit in it. We have found some benefit in them. But with a rider, you must tell the patient that it can do harm too. What we are doing it as, because the role of it is, if it is a viral, the IL-6 goes up, and you can prevent, you can bring down the IL-6, anti-IL-6 monoclonal antibody, it can bring down the IL-6 quite drastically. It's more than 100, 200 IL-6 if you find. Such patients, maybe tocilizumab has a role. Again, this is to say that it is only in those patients who are likely to progress on to the mechanical ventilation or some respiratory failure situation. That is, you need to identify that subgroup of patients from moderate to the severe group. Only then it is very useful. Mild, no use. Moderate, there is a role in a subgroup. Severe, absolutely no role. In category C, I don't think there is any role for that.
But most of the times, so with the demand that so everybody is using in severe cases only.
That they are using it. I think there has to be some kind of a guideline that has to be formulated in the hospital as to when you should use it tocilizumab. It becomes more on demand or on personal preference. I think you need to form a very clear-cut guidelines on when to use this tocilizumab. As I said, tocilizumab can do more harm. Unlike remdesivir, you have to be careful only in liver diseases. Whereas tocilizumab can have a storm. Along with the storm, you can have another bad chest infection, which will worsen him and push him into a full-blown respiratory failure. From where it may be difficult for us to bring him out of that.
Thank you. Thank you very much, sir. Dr. Animesh, sir.
Regarding tocilizumab, right? We have two very good trials. One is the REMAP CAP trial. The other is a recovery platform trial, right? So recovery platform trial is still in the preprint stage. While REMAP CAP trial, it is still it is out. So based on this, tocilizumab has got two clear-cut indications. One is patient with severe COVID-19 who have been admitted recently to hospital. Recently means within 24 to 48 hours, and who are on HFNC or higher form of respiratory support. Now that is as per REMAP CAP. It has been shown that there was around a 3% benefit in mortality, right? So that is one indication of tocilizumab, and the second indication is on the base of recovery platform trial, which I said is still to be out. That is for less severely ill patients. So there the indication is patient is on oxygen, but the patient's condition is deteriorating rapidly. So this definition is again recent deterioration within within again 24 to 48 hours, and where there is increased inflammatory markers. So CRP they have given, so they have used CRP as the criteria here, more than 75 milligrams per liter. So these are the two indications for giving tocilizumab. One in very severe COVID-19 patient who are on HFNC. So you understand, right? A patient of severe COVID-19 who has come and who is on HFNC or NIV or invasive mechanical ventilation, within 24 to 48 hours. Why within 24 to 48 hours? Because you want to be reasonably sure that there is no ventilator associated pneumonia or other problem with this patient, which is actually a contraindication for tocilizumab. So this group of severe COVID-19 patients, they are eligible for tocilizumab. So that is the first indication. And the second indication is patient is on not on HFNC, lower form of oxygen, but is deteriorating. So you have started the patient on steroids, remdesivir, since the patient is on low flow oxygen, and these are not working, and the patient is deteriorating, and you see that the inflammatory markers are very high. They're more than 75 according to this trial. Then that's an indication for starting tocilizumab. So these are the two indications that we talk about. Our guidelines, they have not exactly put it as one or two, but it has talked about severe COVID-19, which has got raised inflammatory markers. It can use it. But what I'm saying is, as at par with the NIH CDC guidelines, it is also at par with the other IDSA other guidelines, which is being used. When you are using tocilizumab, usually one dose of tocilizumab has been found to be effective. 4 to 6 milligrams, some say 8 milligram per kg may be used. You have to be careful about secondary infection, untreated tuberculosis, thrombocytopenia, low ANC, that is low neutrophil count. You have to be careful about. So that is that as far as tocilizumab is concerned from my side.
Thank you very much, sir. Dr. Bhakti.
So completely agree with the speakers so far. The Impactor trial, I think the important thing to remember here is a lot of these trials happened in North America. For example, the Impactor trial, which specifically looked at tocilizumab in mildly COVID patients. Now, in these settings, the prevalence of concurrent tuberculosis and drug-resistant tuberculosis is extremely low. That is not the situation in India. So one of the biggest challenges for providers is to think about what is the likelihood that this patient also has concurrent TB, and it would behoove us to maybe rule out tuberculosis as a complicating factor, as there is a likelihood that treatment with TOSI could be detrimental to these patients and their clinical course. But other than that, I think there is some benefit here. The safety signals from the Impactor trial did not show increased prevalence of adverse events. It was 38 adverse events in the TOSI group compared to 25 in the placebo group. And so with the correct patient without concurrent pneumonia, there is shown to be proven benefit without increased adverse events.
Thank you very much. So I think so remdesivir and tocilizumab is having
Dr.
the
Rambabu?
role. Yeah, Nagesh.
Thank you very much. We have participated very widely in both the recovery study as well as REMAP-CAP study. Both of them are UK studies, and we have recruited a large number of participants into both these studies. And tocilizumab has only become a standard of care very recently after the REMAP-CAP results are published. And we are starting to use it, and it has become the standard of care in our hospital now for admissions to critical care within 24 hours of ICU admission. So again, it is about selection of patients, and my understanding of tocilizumab, it was used like anything, like vitamins in India, long before any of these results are published. So,
Vinay, can you check? Yeah, please. Yeah, Nagesh.
Yeah, so there is a lot of exclusion criteria. There is a lot of contraindications. We have to exclude all forms of immunosuppression, hepatitis, HIV, TB in these patients, and carefully select our patients. And as Dr. Bhakti said, I would be very, very concerned in India, especially with such a rampant tuberculosis, that we subject people to a great degree of immunosuppression without checking our exclusion criteria very carefully. So at the moment we are using it, it has become a standard of care in UK, but very, very carefully selected patients. Thank you.
Yeah, thank you very much. So now we conclude this drugs with it. So if Dr. Chandrasekhar Reddy is, you want to say anything regarding this? He's online. Dr. Chandrasekhar. Vinay, can you identify? Yeah, okay.
Yes,
So, you identified?
yes, sir, Chandrasekhar.
Yeah, Dr. Chandrasekhar Reddy. Can you unmute?
Yeah.
ఎవరు అన్మ్యూట్ చేయండి వాళ్ళని. యా డాక్టర్ చంద్రశేఖర్ రెడ్డి.
So I'm muting all and unmuting. Dr. Chandrasekhar, please unmute yourself. Sir, he is not unmuting. Sir, please unmute yourself. I muted all. Please unmute yourself.
Now okay?
Okay.
Yeah. Right. So now we can move to the steroids. So just I want only one question. Shall we use the oral steroids in a mild cases? There are so many things. So I have seen now AIMS partner guidelines where they wrote that metred or the prednisolone for the mild patients, just outpatient. I was a little surprised. So, Animesh, so can you, what's your take on it?
No, so so steroids are absolutely, I think, the maximum benefit, mortality benefit, and the maximum data is about steroids, but that is only in moderate to severe COVID-19 patient. So somebody who has saturation more than 94% or above, who is having respiratory rate of less than 24, and who otherwise falls within the category of mild COVID-19, has no business using steroids, right? So there is no data whatsoever to suggest that we should be using steroids in mild COVID-19. In moderate COVID-19 and severe COVID-19, obviously there is mortality benefit and it should be used in almost all patients.
Yeah. Narasimhan sir, any role of oral steroids in asymptomatic mild cases? So many people are using. Narasimhan sir?
If I can add just a small point to it,
Yeah.
Professor Rambabu, right? So what we are also seeing is that a lot of patients are getting their CT scan done even during home isolation, even when they're having mild COVID-19, and they're returning with a number. So CT scan says anything more than 9 is moderate, anything more than 15 is severe. So I'm talking about CTSS, CT severity score. So a lot of people, and I think some doctors are also doing it, they are equating this moderate COVID-19 or severe COVID-19 according to the CT report as indication for giving steroids. So here again, all the trials, right? All the trials, they have only given steroids in those patients where the oxygen level has fallen down below 94%. So it does not matter what your score is on CT scan, whether it's moderate, severe, mild. So obviously, we are not talking about, if your saturation is normal, if your respiratory is normal, then there is no indication for giving also steroids in these patients who are home isolated and who are otherwise having a so-called abnormal CT scan.
So you mean to say that CT severity index, if it is less than 8, so you don't want to go for the steroids?
No, sorry, I did not say that. I said that CT score can be anything. It can be 12.
Okay, whatever it may be.
Whatever it is, patient saturation has to be seen, patient symptoms have to be seen, and patient's respiratory rate has to be seen. If they are normal, if they are not qualifying for moderate to severe COVID-19, steroids have no business around that patient.
But most of the practitioners are afraid about that patient may land it into the cytokine storm.
So this is where we are talking about evidence based medicine, right? So if there is no evidence for ivermectin and there is no evidence for vitamin D and vitamin C and hydroxychloroquine, you have to also accept that at this moment there is no evidence for showing that a CT scan of particular score, say 10, 11, it is an indication for giving steroids. So because there is a lot of times there is clinical radiological, there is a discrepancy. So our entry point, our indication for for picking up patients for steroids should be on clinical basis only. It should not be on the basis of CT scan score. So even mild patients with so-called moderate to severe tag on CT scan, they should not be getting steroids. That's what my submission is.
Yeah, thank you. So Dr. Narasimhan is online. Vinay,
Any
can you check?
comment, sir? But sir, Narasimha garu, please unmute yourself. As your co-host, you can unmute yourself. So we're not getting any response.
Yeah, okay. So anyhow, so only I want to ask the Dr. Animesh and the Narasimhan regarding the oral steroids, because I don't think so that anything happen in USA or UK, Dr. Bhakti?
So the data is the data, right? There is benefit to oral steroids. One of the things that we have noticed.
Oral steroids.
Yeah.
For early patients, mild patients.
For patients with hypoxia.
No hypoxia.
Regardless of severity, no benefit for no hypoxia. But one of the challenges that we're also seeing in the hospitals is that there is a desire to continue steroids past 10 days. So we are now seeing cases of patients with prolonged use of steroids greater than 10 days. And that is a practice that is not beneficial. The course of steroids is only beneficial for between 5 to 10 days. Prolonged steroids or steroids at a higher dose, right? So 60 milligrams once a day or 20 milligrams TID have also shown no benefit, even though that is a practice that we're seeing. So more steroids or steroids for a longer duration are also not beneficial.
Okay, thank you very much. So everybody is agreed that steroids are having the role. So just I want to clarify only any role of oral steroids for the mild patients for the outpatient. I don't think so that so all the speakers are not accepting. So
Dr. Rambabu,
yeah.
Sorry to come in again.
Yeah.
I think it is potentially harmful that people are given this medication when they actually do not need it. So the reason being, it is a simple pathophysiological process. It is only when the pneumonitis, the steroid is an anti-inflammatory and should only be used when there is evidence of pneumonitis. Pneumonitis as in a clinical presentation and a clinical picture. This is a clinical, the whole thing has to be managed clinically rather than radiological. There is no correlation between the radiological findings and the clinical presentation, because people we have noticed have got diffuse bilateral infiltrates that have not even required oxygen therapy. And on the contrary, the patients that have required a mechanical ventilatory support has had little changes on their CT scan. So this is something that should be judged based purely on the clinical presentation rather than a radiological presentation. So I think giving steroids in mild cases is potentially harmful and should actually be discouraged. This is only for hospitalized population that are on oxygen therapy and beyond. Thank you.
Okay, thank you very much. So now we move to the everybody is agree with this one. So only my clarification is now whether it is D-dimers increased, ferritin increased, whatever it may be. Once the patient is admitted for the moderate to severe disease, it's a protocol that they are giving to everybody as a prophylactic dose. What Dr. Animesh said.
So I did not hear your question. You said about the dose.
Just for everybody, just the patient is admitted. So whether it is inflammatory markers, D-dimer, ferritin, everything is normal. But they made the hospitals, made the protocol that For everybody, is a single dose of the LMWH 0.4 mg for them.
No, so the indication for again anticoagulation is moderate to severe COVID-19, right? Or those patients of mild COVID-19 who has been hospitalized for some other indication which requires, anticoagulation. So anticoagulation, so anybody who's requiring oxygen for COVID-19 has to get anticoagulation. Again, the dose of anticoagulation, it was a matter of concern. Previously, it was thought that, one can base it on the D-dimer level. But now, some trials have come. There's one inspiration trial, etc., which have shown that the anticoagulation need not be titrated to the magnitude of D-dimer rise. So what I'm trying to say is that all cases of moderate COVID-19, all cases of severe COVID-19 who require oxygen, unless they are having clinically proven venous thromboembolism like DVT, pulmonary embolism, they should all be getting once a day dose of or prophylactic dose of low molecular weight heparin. So that's what the standard of care is, and that is also included in our protocol.
Yeah, thank you, Dr. Bhakti.
So the protocols that we're using in the United States, we do see benefit with prophylactic low molecular weight heparin. There is no benefit so far of therapeutic dose heparin, i.e. 1 milligram per kilogram BID or 1.5 milligrams per kilograms once a day. Another strategy that has been used and which is a part of our clinical protocol is to use the HAS blood score, which I've put in the chat here. HAS blood and identify those that have an increased risk of bleeding once placed on low molecular weight heparin. And in those patients, for sure, you should only be doing prophylactic dose. You should definitely not be doing anything greater than the standard prophylactic dose for low molecular weight heparin. Another thing that I just wanted to alert this group to is that there is, for patients who are going home and receiving care at home but are bedbound, there may be some physicians that may want to consider sending those patients home with low molecular weight, self-administered low molecular weight heparin. The challenge in these patients is when they're at home, who or how will you recognize an increased bleeding risk? And so it needs to be a discussion about the risk versus benefit and the patient's risk factors for having a pro-thrombotic state. But overall, that is not a recommended practice, and it's certainly not being practiced in the United States. So sending people home with low molecular weight heparin, even though they may be bedbound, has not been practiced widely.
Thank you. So everybody is aware, so low molecular weight heparin and steroids, so we're supposed to use. Only my take is that shall we streamline for every patient? So I got the answer for that. So thank you very much. So next, oxygen. So everybody knows that is streamlining of this one. So it's a very big topic itself. So now this is the question about that. What happened to the convalescent plasma? So it's vanished almost when compared to the first wave. So take on for the animation.
Yeah, you're right. So again, this has been relegated to the the off-label use. Convalescent
I think
plasma,
particularly in Delhi, most of the plasma banks was established.
yeah, right. So one of the several lessons that COVID-19 is teaching us that every therapy which shows promise ultimately lives up to its expectations. So that is definitely not the case. So initially there was a lot of hype about convalescent plasma. Now we had several trials. One of the important trial organized by ICMR was the PLACID trial. Now it showed that though there was again some issues with the the study, because it was seen that the majority of the samples, they did not have adequate amount of the antibody level which is required for a convalescent plasma to be effective. But this is in line. I mean, the ultimate the outcome, the ultimate result of this study, PLACID trial, it showed that convalescent plasma was not really helping. This is also in line with most of the other trials which have been done from all over the world. Convalescent plasma is not really helpful. Probably a group which might not benefit is the patients who are presenting early, who are again not very advanced in their COVID-19 disease, that is, they are not on mechanical ventilation, and within the first 7 days, because again, convalescent plasma is more like an antiviral. So if at all it is acting, it would be acting early on, right? So in
most of the VIP patients admitted with you with the pressure or anything, so still you are giving in the second wave?
No. So it's very common, uncommon that even a blood banks are saying that they are not getting that request, because
That's what. So I want to ask you, if you really want to give the plasma, how you are going to choose the patient? Most of the people are vaccinated now.
Yeah. So I mean, again,
and also second wave, there is a very few days of the patients are available with you, not with the 28 days after patients. I think that to get the plasma is also difficult.
Exactly, procuring it is very difficult, and for it to tick all the boxes, that is also very difficult. So convalescent plasma, I mean, I think nobody is enthusiastic about convalescent plasma nowadays.
Yeah. Nagesh, what's your take? Yeah, okay. Dr. Bhakti?
So I agree wholeheartedly that the data does not support convalescent plasma. It is still inconclusive. And I hate to do this on a call of this size, but anecdotally, my husband was in the ICU critically unwell. And the one therapy that I was able to procure for him was convalescent plasma, and he turned around in 24 hours. So one of the things I learned during that experience and in discussion with the leadership at Johns Hopkins was that convalescent plasma effectiveness is really dependent on the titer of the antibodies that are being given to the patient. And so many of the clinical trials early on that looked at convalescent plasma did not look to see what the titers of the antibodies were. I do think it's a very small subset of populations that benefit. I think it's challenging to measure titers. I think it's also challenging to get that therapeutic to the patient within the time frame where it could possibly be effective, i.e. prior to the cytokine storm setting in. And now also with the advent of vaccinations, there is unlikely to be long-term utility in investing in convalescent plasma. Dr. Ray, feel free to.
Yeah, sure. So initially we had, as you said, I'm very happy to know that in your case personally there was a turnaround. But again, we are looking at not one particular instance. We are looking at, I would agree, you would agree that to the vast majority of trials that have been done. So probably not much of benefit that we can say, as you rightly said, right?
Thank you. So just quickly, so we will finish, Dr. Ray.
Sure.
Recently, so DCGA approved this interferon regulated. Are you started or still you want to start?
So Virafin, interferon 2B has been,
2B.
I think yesterday or day before, has been approved by DCGI. Again, so the pharmaceutical company, Zydus, it talks about 2 trials. They have quoted 2 trials. One was incidentally done in Delhi itself, but again in NCI Jhajjar, it played a small part of it. But again, it's a small cohort of patients, 40 patients, phase 2, and phase 3 there are 250 patients, right? I went through the trial. I'm not very impressed with the trial. Again, it talks about early recovery and this and that. So my take on this is that this is too early to talk about interferon 2B. Solidarity also had an arm where interferon 2B was there, but it did not pass master, right? So I don't think that we should be thinking about, again, fancy drugs. COVID has kind of made us realize that what really works is oxygen, anticoagulants, and steroids, right? OAD kind of, or DOA, what do you call it? So others, remdesivir, tocilizumab.
In Solidarity trial, they included the interferon also, but not that much comment on this.
Yeah, so I think it's still in the
they are still in process.
Yeah, still process in analyzing it. So it's a very big study, and I think they take a lot of time in analyzing it and getting it published before they talk about it, right? But as of now, no evidence to say that it works.
Yeah, before going to audience, so why IV immunoglobulins are not encouraging? So are you tried at your institution?
No,
when it
again,
is freely available?
No, again, a few studies with with small sample size, they have showed that IVIG they work wonders. But again, I'm not aware of any randomized control trial, any well-designed study which says that it works uniformly, consistently in any particular COVID-19 group. So most of them, the experiences with very severe COVID-19 patients, they are not responding to any other treatment. So you end up giving IVIG. But again, I personally don't have much experience with it, and I'm not aware of any study which looks at that. So that's the reason why our department, our institute had decided not to include IVIG. So those are not even there in our algorithm.
Yeah. Okay. Thank you. Anyone want to go for the comment about IVIG? Anybody is having experience? Dr. Bhakti, Dr. Nagesh? So if no more are there, so there are a lot of questions there. Vinay, can you identify anybody raising digital hand?
Dr. Rambabu, I need to jump off momentarily, but I just want to echo what Dr. Ray said, which is there is no magic bullet here, right? Certain drugs have been shown to be beneficial, but those are in subsets of populations. The magic bullet to saving lives is really good, honest medicine, symptomatic support, oxygen therapy, early recognition and management of complications of COVID-19. And so building our cadre of healthcare workers, training those who are unsure of their practice or being put into their comfort zone is how we're going to be most effective against this horrible disease. So thank you so much for inviting me to join this discussion today. And good luck with your efforts and your continued management of the pandemic.
Thank you, Dr. Bhakti. So thank you very much. So anybody is digitally handed?
Yeah, there are a couple of hands raised.
Please.
Vivek Avasti, can you please proceed with your question?
My question is about leronlimab, a CCR5 inhibitor. Back in March of 2020, when we had a mortality about 80-85% in patients who were intubated, we found that the mortality came down to about 17%. This was shown by Dr. Bruce Patterson when we had the CD10 and the CD12 studies. We showed that patients have an 82% benefit over standard of care in the critical or severe patients at week 2. So we gave the drug sub-Q on day 0 and day 7. The FDA stopped them from giving it on day 14 and day 21. When you find that in comparison to dexamethasone, remdesivir, tocilizumab, bamlanivimab, you find a drug that is 5 times more effective. You find that there is nothing in the world compared to this. When the Philippines is giving a CSR to it and allowing the ex-president of the Philippines to be saved by this drug, why isn't India even looking at a drug that can basically change the course of history in India? Why are you not looking at it? Thank you.
Yeah, Dr. Ray, can you take?
No, I'm sorry, I did not get the name of the drug. Which drug are you talking about? Are you talking about
leronlimab?
Leronlimab, Leronlimab, made by Cytodyne in Vancouver, Washington.
Okay, great. So I would plead my ignorance. I am not aware of this drug, right, and what it does in COVID-19. But if you don't mind, my answer to that can be a little generic. I don't think it has been included in any of the guidelines, WHO, IDSA, CDC, because we keep updating these guidelines, our guidelines also, and we keep looking at the different guidelines. So if there has been any drug which shows, stupendous success, as you're saying, then it has to be printed somewhere, and it has to be in the realm of public domain, as we call it. So once it is there, I think it would be a good idea to pour through that particular study, and if the benefits are, as you are saying, probably it is right, then we need to look at the study. But till the time I do that, till the time other people do that, it cannot be included within the guidelines.
Sure, sounds good. But I wish,
Dr.
in the future, in case you do have time and you were to look at the CD12 study, or you were to look at Bruce Patterson, who basically, see, we look at COVID more as the long haulers now, as 10% of people develop long hauler syndrome. It's almost a form of HIV, literally, that has come about, where you have a long duration of brain fog, fatigue, tiredness, chest pain, and we are doing a lot of studies in the US trying to see what we can do to ameliorate this disease in the long term. If maybe in the next 2 or 3 months leronlimab comes across your slate, I would appreciate if you were to take a look at it, please.
Sure,
Thank
I
you.
will do that. Thank you so much. Thank you so much. I
Yeah,
would
thank
definitely
you.
do that.
Thank you so much for your information, sir, and sharing your experience. Vinay, anybody is want to ask? Because most of the chat box questions are answered by the speakers already, Dr. Bhakti and Ray.
And there is Dr. NJKR.
NJKR. Yeah.
Yeah, good evening, sir. Two questions, one to the panelists and one to yourself. Question to the panelists is, sir, do you have any experience with baricitinib? It has been shown in Act 2 study, but baricitinib and remdesivir has better results. To the host, who's a nodal officer for AP, sir, we are seeing doctors prescribing as they wish, whatever drugs they want. Are you taking any actions to curb those things? Thank you.
Animesh, baricitinib, Janus kinase inhibitor.
So JK inhibitor, baricitinib. So there's some data regarding this. It's also available in our country by the trade name Olimiont. It comes in 4 milligram tablets. Now the issue with baricitinib is, again, the data is from Act 2 trial, where they have used baricitinib in only those patients who are getting remdesivir without steroids, right? And in that study, it has been shown that there is only faster time to recovery. So you compare it with the results of, say, recovery trial, where steroids have been shown not only to decrease hasten recovery, but also it shows mortality benefit, right? So CDC guidelines, they talk about baricitinib only in that light, that if you're not able to give steroids, you use baricitinib, and always in conjunction with remdesivir. Now, I implore you, I request you to think about a situation where that is possible in our patients. Our patients who cannot get steroids for any reason. What can that be? Hyperglycemia, infection. I mean, we can give it under cover of insulin, and we can give it under cover of antibiotics. So there is very a rare patient, none that I've seen, where you can think about using baricitinib in place of steroids. Right. So I think the use of baricitinib in our setup would be very, very limited, especially when you are using steroids.
Yeah. Thank you very much. So the next question, so what he asked about this prescriptions by the practitioners. So it's not only for this COVID. So for any disease, so it's a clinician's criteria. When the fever case comes, so I may write some of the antibiotic and you may write some of the thing. So there will not be any control for the particular of when the guidelines and the known cases are there. If you know that it's a typhoid or the viral or the dengue, in spite of that also there is a lot of prescriptions maybe there, because clinicians feel that so that is better. And when it is so much of confusion and there is no evidence is there, still one paper says that this is good and another one says that my experience is so better with this drug. So it's very difficult to take any action on those people. It's only my request to the medical fraternity that please follow the guidelines, what we are giving from the government of India, from the state governments, So please follow that. So you are going to save the patient and give the best results to the patient rather than Vincent fancy drugs. Don't write. That's only my request from my side.
So can I add on to that? I mean, I
Yeah,
think this is a
please.
very, yeah, thank you. So this is a very important question. I think the one of the most important thing is, say, it's very difficult to penalize somebody, as Professor Rambabu just said, that just because you're not writing this, because there's something called the physician's discretion as well. He might choose to do something, but I think there are some issues with COVID-19. Not beyond the indiscriminate use of remdesivir or tocilizumab. That is, the use of antibiotics, right? So previously doxycycline, azithromycin was there; it's no longer there. But what I see, invariably, patients of mild, moderate, severe COVID-19, they get antibiotics. For mild COVID-19, it may be something as, say, coamoxiclav, cefixime, which are clearly not indicated. Moderate and severe COVID-19 patients also, they end up getting antibiotics. So depending on where you are, you might end up getting meropenem, you might end up getting teicoplanin. Some people use, they have a short trigger for using antifungals. So clearly this is not working. Different guidelines, including CDC, they say that the next epidemic is going to be of antimicrobial resistance, which is already brewing. So I think we should be very careful with our drug choice. We should not be using any drug which is not found to be beneficial, which can actually harm you. If it is true for ivermectin, if it is true for hydroxychloroquine, which I concede that they are soft points that we should be using them and not using them. But for antibiotics, I think there's enough evidence to show that don't use it in your mild COVID-19 patient. Don't use it unless you feel that there's a super added infection in patients of moderate to severe COVID-19. Now in India, there is no legislation which can prevent us. So I think we would have to be the vanguards, the people who can ensure this. So we can always look for a way in which we can de-escalate if we are using antibiotics, or we can use a way in which mild COVID-19 we are not prescribing antibiotics, anything at all, just because we feel that it might cover some super added bacterial infection, because clearly evidence does not speak in its favor. You would agree to that, Professor Rambabu?
Yeah, that's only. So it's not possible because not only for this COVID, so it's a physicians or the treating doctors criteria, not to go totally deviated towards in spite of all the guidelines are there, that may be different. But is in somebody say the oral steroids, because I have seen that AIMS partner is oral steroid, NIMS is the oral steroids, some Apollo guidelines are there. So because somebody will read that one, so you feel that it's institution, and they will go on that. So like that, so it's an individual. Finally, so we will write underneath that it's a treating physician's discretion. So that's a very important one. So I think so. Any more questions, Vinay? So I think Sunday, so we took a lot of time.
Uttaraja University, I wanted to ask a question.
Yeah, please. Yeah, Dr. Sudhakar, so you want to ask anything?
Yeah,
Dr.
sorry to interrupt.
Yeah, please.
So I'm a hematologist from University of Nebraska, and I have a couple of comments to make. One is about the anticoagulation. Right now, for hospitalized patients, the American Society of Hematology guidelines are using prophylactic low molecular weight heparin or unfractionated heparin. There's no role for therapeutic doses unless there's evidence of DVT or pulmonary embolism or any form of clotting. So we're routinely not using therapeutic doses, number one. Number two is I see a lot of Indian doctors prescribing low dose apixaban at DOAC as soon as they get a positive COVID patient who is getting a home kit, and they're routinely including low dose anticoagulation. I'm wondering if there's any data for that. I haven't seen any, number one. I saw Dr. Awasthi asking question about bamlanivimab. That's basically a monoclonal antibody. There's a couple of monoclonal antibodies that have been approved by FDA here for emergency use. But there's no data to suggest that they do anything for progression or survival benefit yet. So we're using them in high-risk patients and not routinely in all patients.
Thank you, Dr. Raja. So, Animesh, so you want to add anything?
Yeah, sure. So I agree that there is no role of giving any NOAC, APCOVinar, dabigatran in any patients who are being home isolated. The use for oral anticoagulants, it comes when you're wanting to discharge the patient, and you feel that the patient requires prolonged anticoagulation. So one score which we use is improve VT score, which it says that if it is more than 4, there are some points like present cancer, past history of VT. I'm sorry. I mean, if it sounds a little didactic, I'm just trying to just spell it out for for all the viewers. So cancer, mobilization like recent surgery, fracture, past history of VT, cancers. So hypertension, age. So there are 7 points, and out of 9, you give a score of 4. If it is more than that, then the person has an indication for having some anticoagulants. So the choice is between low molecular weight heparin and something like a NOAC. Rivaroxaban has been shown to be of some benefit, but I completely agree there is no benefit in giving it in mild COVID-19 patients or all those patients of moderate to severe COVID-19 who are being discharged without having a high improved VT score. That is one. Secondly, monoclonal antibodies. It's not available in India, so as of now we are not concerned with that. Regin COVID-2 and other cocktails. So as you said, probably they might be of benefit in mild to moderate COVID-19 who are having high risk. So there is some data which I could understand that there might be a lesser chance of progression to severe disease. But as of now, we have no recommendations regarding it because thankfully or not thankfully, it is still not available in our country.
Thank you, Dr. Ray. Dr. Sudhakar, Dr. Sundaracharya, Dr. Prem. So anybody want to add anything? Yeah, Dr. Avasthy. Yeah, Vinay, can you unmute?
So who's a Vivek, Dr. Vivek Avasthy?
Yeah. Now you can.
Oh, okay. See, as far as bamlanivimab is concerned, I've used it on about 30 of my patients. It really makes no difference. In fact, it's been stopped now because of the variants that have come in. It's only now allowed along with Regeneron's, so there are 2 antibodies that they give together instead of just one that they used to. That was it in regard to Dr. Uttaraju's the comment about my talking about monoclonal antibodies. What is important really is as these variants come along, these monoclonal antibodies are going to be hitting the wrong part of the spike protein. It's the same way we'll have to keep changing our vaccines in regard to the domain. It's going to keep changing. You're just going to have to keep. In my mind, the immunomodulators, either CCR2 or CCR5, will be what will change this pandemic. It really will, because what these drugs do is they bring the CD4 CD8 count back to a normal ratio and allow the CD8 to become killer cells again. They allow the body to kill the virus. So no matter what the mutant is from P1 from Brazil or from South Africa or from England, it doesn't matter. These immunomodulators take on the cytokine storm by bringing the body back to its immunocompetence. So all the stuff that we're doing, antivirals early in the disease, is not necessary. 98% of my patients, I've had about 300 COVID patients so far. I've lost only 5. I shouldn't say lost only 5, but most of them don't require any treatment. They don't even know they have it.
Okay. Thank you very much for your comments. But still, it is not available with us. What is the cost of the drug?
In the Philippines, it's about almost $500. So that means if you take 2 shots, basically you have a 5 times chance, 400% chance being alive when you're severe to critical. It is in clinical trials. I think it's being started off in Gurgaon next month. I'm not sure if one of the other doctors here is taking part in the clinical trials for leronlimab, but if you're not, I would request you do. It you'll find you'll change the course of Indian history.
Thank you. Thank you very much for your suggestions and your sharing your experience. If no further more questions, I thank particularly Dr. Animesh. So you are giving so much of time to us, and you are the contact point for the prestigious institution, All India Institute of Medical Sciences, and covered almost most of the questions. And thanks to the Dr. Bhakti, so woke up at 5 o'clock and joining, and Dr. Raju, Dr. Avasti from the USA, so early hours of the morning, Sunday morning. And also I thank Dr. Narasimhan, who is a very busy practitioner and a senior pulmonologist of Apollo, Chennai. So thank you one and all participating in this. And with this, I conclude this Zoom conference and I am closing this conference. Thank you one and all.
Thank you.